Greetings, Mauritius. I'm Dr. Mamatha, Associate Professor from Department of General Medicine, ESI Rajajinagar, from India. Today I'm here to report a rare case of pathological fracture in adults as a hypophosphatemic rickets. Before going to the case report, first we'll have an introduction regarding the phosphate. Phosphate plays a critical role in bone mineralization, and its homeostasis is maintained by dietary intake, gastrointestinal absorption, renal reabsorption, and renal excretion. So, blood phosphate concentration is maintained by these systems as well as the movement of phosphate in and out of bone and the intercellular space. So, hypophosphatemia can occur as a result of low dietary intake, decreased gastrointestinal absorption, or lack of renal conservation. So, the clinical sequelae of hypophosphatemia results in defective bone mineralization and hence the rickets phenotype. Hypophosphatemic rickets is a type of hereditary rickets characterized by persistent hypophosphatemia and hyperphosphaturia. It is caused by mutation in the gene encoding the phosphate regulating endopeptidase homolog X-linked, which is identified in 1995. It is a rare form of rickets, causes deficient calcification and mineralized structures such as bones and teeth. The most common mechanism for hypophosphatemic rickets is a renal phosphate wasting mediated by increased fibroblast growth factor 23. So we come to know now it is a disorder of defective bone mineralization due to defect in renal phosphate handling process. It is characterized by increased phosphate excretion, which is accompanied by increased phosphatoins like fibroblast growth factor 23. So phosphatoins is nothing but phosphaturic peptides. So it can be a hereditary form of three types, that is X-linked, autosomal dominant, autosomal recessive type. It is associated with low serum phosphorus, normal serum calcium, and inappropriately low to normal vitamin D level. So correct identification of these disorders is important for determining the therapy. Early diagnosis and management prevent subsequent complications of the disease. Here we report a rare case, that is a 44-year-old male born from non-consanguineous marriage presented with history of low backache, localized, dull aching, and non-radiating pain, which is aggravated by activity, relieved by taking rest. All these symptoms were there since 1 year, and along with this, the patient had proximal muscle weakness of lower limbs. That is also since 1 year. And there was no history of distal muscle weakness of lower limb, no history of sensory involvement, no history of bowel and bladder involvement, no history of weakness of upper lip, no history of trauma, no history of fever, no history of comorbidities. Family history was insignificant. There was no history of drug intake. There was no history of weight loss or loss of appetite. On examination, the patient was well built, nourished with height of 160 centimeter, weight 50 kgs, and BMI of 19.5 kg per meter square. Vitals were stable. There was no dental abnormalities, no deformities of chest, deformities of limbs, or there's no kyphoscoliosis. Central nervous system examination revealed higher mental function was normal, all cranial nerves were intact, the bulk was normal in all four limbs, tone was normal in all four limbs, and power at bilateral hip joint was 4 by 5. Rest of the joints were normal. And all reflexes were intact, that is the superficial and deep tendon reflexes. Bilateral plantar were flexor. The other sensory and cerebellar examination was normal. The only positive findings was lumbar spine tenderness elicited at L4 and L5. And other systemic examination was also normal. So we made a clinical diagnosis of lower limb paraparesis of metabolic cause. Coming to the lab investigations, the hemoglobin was 13.9 gram per dl. WBC was 6,730. Platelet was 2.12 lakh. Peripheral smear was normocytic normochromic. ESR was 17 mm per hour. The serum total protein, serum albumin, and albumin globulin ratio was normal. The renal function test, serum electrolytes, thyroid profile was also normal. CRP was negative. And serum calcium was 8.9 milligram per dl. That was the normal value. The serum phosphorus was 1.7 milligram per dl. That is very low. The normal value is 3.5 to 4.5 milligram per dl. The serum alkaline phosphatase was raised. The normal is up to 140 units per liter, but in our patient, the serum alkaline phosphatase was on the higher side and serum phosphorus was low. And 24-hour urine calcium, 31 milligram per 24 hours, that is also normal. 24-hour urinary phosphorus was 2.6 gram per 24 hours, that is, it is increased. Here the urinary phosphorus excretion was more. And 24-hour urine protein, 21 milligram per 24 hours, that is also normal. And we checked urine for amino acids, which turned out to be a negative. Arterial blood gas analysis was also normal. And serum 25 hydroxy vitamin D was 33.2 nanogram per ml. That is also normal. And serum PTH was 65.7 picogram per ml. That is also normal. And ratio of tubular maximum reabsorption of phosphate to GFR, that is laminar filtration, was 0.215. And HLA B27 typing was negative. Ultrasound as a part of investigations we did, that was also normal. And MRI lumbar spine revealed no significant neural compression. And MRI pelvis and bilateral hip joint was suggestive of pathological fracture that is found in neck of right femur with surrounding marrow edema. We did a bone scan which revealed osteoblastic activity which was increased and osteoporotic changes in the head of both the femur, sacrum, condylar region of both the tibia, the right 9, 10, 12 rib posteriorly, and bilateral scapular region. Showed more of osteoblastic activity and also osteoporotic changes. And we did fibroblast growth factor 23, that is, it was very high, 308.2 RU per ml. And we did FDG PET scan, which revealed mild osteopenia, no focal lesion identified to suggest primary neoplastic lesion, and other findings was normal. So in our patient, on investigation, we found that serum calcium was normal, serum phosphorus was on the lower side, serum alkaline phosphatase was on the higher side, and vitamin D was also normal. The excretion of phosphorus 24-hour urine was on the higher side. So since we had a phosphaturia, we did amino acids level to rule out other causes, but it turned out to be a negative. And PTH was also normal. So we came to know there is phosphaturia, renal wasting process. So based on that, we worked up for ratio of tubular maximum reabsorption of phosphate to GFR, which showed a very low value. Based on this findings, we did FDG, PET CT, and fibroblast growth factor 23. And fibroblast growth factor 23 was on the higher side, which is one of the phosphatide, phosphaturic polypeptides. And bone scan revealed increased osteoblastic and osteoporotic. We didn't get much conclusion from this, but we got that fibroblast growth factor 23 was on the higher side. So now coming to the discussion. So this hypophosphatemic rickets is one of the hereditary form of rickets, which is due to renal wasting of the phosphate. Estimated incidence is 1:20,000, which is caused mainly by the mutation of phosphate regulating gene, that is phosphate regulating gene with homology to the endopeptidases located on X chromosome. It is basically inherited as X-linked dominant, and this basic physiological defect is impaired proximal renal tubular reabsorption of the phosphate. So inactivating the mutations in PHEX results in increase in synthesis and secretions of fibroblast growth factor 23. So the increased circulating concentration of this fibroblast growth factor 23 is responsible for the biochemical phenotype of X-linked hypophosphatemic rickets like phosphaturia, hypophosphatemia, and inappropriately low or normal vitamin D concentration. So this fibroblast growth factor 23 is a protein synthesized by osteoblasts and osteocytes, which inhibit the phosphate reabsorption by the renal tubule. And if secreted in excess, leads to the hyperphosphaturia and subsequent hypophosphatemia. So serum concentration of FGF23 is usually high in these patients. Biochemical features includes hypophosphatemia, high serum alkaline phosphatase, and reduced tubular maximum reabsorption of phosphate to GFR and suppressed to normal vitamin D concentration. Here, usually serum calcium is normal, but secondary hyperthyroidism is common both before and after treatment with phosphate. So a diagnostic evaluation include fasting serum and urine phosphate and creatinine to determine the tubular threshold maximum for phosphate. And here we should do vitamin D level to exclude vitamin D deficiency. While vitamin D in X-linked hereditary rickets is inappropriately low or normal, and parathyroid is frequently mildly elevated or it can be normal also. So here our patient had a normal serum calcium, patient had a bit of lower limit of normal vitamin D, normal PTH, hypophosphatemia was there, hypophosphaturia was also there, and when we did fibroblast growth factor 23, it was elevated. And when we calculated tubular maximum reabsorption of phosphate to the GFR was suggestive of very low, which in turn concluded that the patient has a renal phosphate wasting disorder, and hence hypophosphatemic rickets of hereditary form was diagnosed. So the medical management aimed at supplementing the oral phosphate up to 2 gram per day and vitamin D analogs 1 to 1.5 microgram per day. And our patient was started oral phosphate 1 gram BD dose daily and calcitriol of 1 microgram daily. The patient improved symptomatically over a period of 2 weeks. And hypophosphatemic rickets, patients will not improve only by supplementing vitamin D, but also we should supplement oral phosphate, and patients should undergo monitoring of serum alkaline phosphatase, serum calcium, serum PTH, serum creatinine, and 24-hour urinary phosphorus for every 6 months. And patients should visit OPDs for follow-up. So our case, we did a final diagnosis of hypophosphatemic rickets of hereditary form, and we supplemented the patient with phosphate and also vitamin D. So over a period of 2 weeks, which patient had a proximal muscle weakness initially, the proximal muscle weakness was also improved. Patient was able to walk without any support, and patient was followed up frequently. And we did a diagnosis of hypophosphatemic rickets of hereditary form. Conclusion: phosphorus plays an important role in bone mineralization. Even though hypophosphatemic rickets is a rare cause of pathological fracture in adults, it requires high index of suspicion, and early diagnosis and immediate treatment of hypophosphatemic rickets is of utmost importance as it prevents subsequent sequelae. These are the references.